All right, so part two of this is moving on to the rest of the alphabet, moving on to circulation. This is broadly, we're trying to look at any potential site internally or even externally that could be losing blood, hemorrhaging out. This includes central peripheral pulses, skin color, temperature. You're also looking at vital signs. This is the time where you're putting somebody on the monitor, getting 2 large bore IVs with appropriate labs, whether it's a trauma major, trauma minor, and getting the 2 pink tops. This also includes that a lot of people think it's just that. It also includes, like I said, potential areas of loss of blood. So in the pelvis, you can lose potentially 2 liters of blood in an unstable pelvic fracture. In long bone femur fracture, you can lose 1 to 1.5 liters of blood. A lot of people kind of tend to put this into either the kind of exposure or secondary survey, but these are areas where the patient's going to be bleeding out, and it's important to have to get that exam in with circulation. It also includes an EFAST exam, looking for attention pneumothorax, looking for cardiac tamponade, making sure that they don't have gross hemorrhage in the abdomen. When we start talking about a positive FAST exam, there's a big gray area in terms of, we have a positive FAST exam, this patient is hypotensive, what's the next step? Are we going to go to CT or are we going to go right to the OR? There's a nice little, not necessarily mnemonic, but just a friendly reminder that we can use with these patients. If they're hypotensive, have a positive FAST exam, we can put them into one of 3 categories based off of blood transfusion, or at outside facilities you can do a liter of fluid, but I don't even want to talk about that. So I'll get heated. But let's talk about giving this patient a unit of blood. So if we give them 1 unit of blood and their blood pressure comes up and it stays up, that patient is a responder to the blood. That means this patient is stable to go to CT for further imaging, for a definitive look at what's going on. On the total flip side, if we give this patient a unit of blood and their blood pressure does nothing, this patient is a non-responder and they need to go directly to the OR for an XLAP. These are some of these like trigger words that you can use, like that kind of flip the room and get different ideas in the resident's head. You say this patient is a non-responder to blood products. They think, oh yeah, this patient needs to go to the XLAP, or this is a patient safety issue if we go to CT for this. The third category, and this is kind of the gray area, is a transient responder. You give this patient a unit of blood, their blood pressure comes up, after a few minutes it goes back down. Kind of have to make a decision. We can continue to give this patient blood while we go to CT, or if we know that this patient is already bleeding in the abdomen, CT is not definitive management of this patient. The best way to see what's going on in somebody's abdomen is to open them up. So the CT is helpful, but the fix is to go to the OR. So that's a transient responder. Just kind of helpful reminders to remember what we're doing with these hemorrhagic patients. The other thing to kind of think about here that I really like to incorporate in my practice is shock index. Shock index is heart rate divided by systolic blood pressure. It's typically around 0.5 to 0.7. Think about a patient with a heart rate of 60 and a blood pressure of 120 systolic. As those numbers creep closer together, the heart rate goes up, their systolic blood pressure goes down. You're getting closer to a number of 1. If they're above 0.9, they are in early shock. If the higher you get, let's say you have a heart rate of 120 and a blood pressure of 60, that's a shock index of 2. This patient's in shock. You need to start moving quickly, give them product, transfuse them, reverse those numbers, and fix the bleeding, or your patient will die. See what else we got. I think that's good.
And yeah. Just something to touch on with our IV access. So a vascular access isn't only based, the amount of time it takes to get a unit of blood or a liter of fluid into someone isn't solely based off of the gauge of the needle. It's also the length of the tubing. So I would like to just make a point that if you have 2 really solid 18 gauges or even an 18 and a 16, that's actually better than having a triple lumen central line because of how long the line is once it gets into the skin. And just a reminder that if that central access is all that we have, we can use the Belmont through that, but it's preferred if we save that for medications or like I'll call adjunct fluids, because we don't want to give these patients fluid, we just want to give them blood, and we should be running the Belmont through either 18, 16, or 14 gauge IV, or through a cordis, through the cordis of the central line, not one of the three tails. Because even the largest tail there is usually a 16 gauge, but because of how long it is, the flow rate is actually less than a peripheral 16. So sometimes that's counterintuitive. We have the residents that want to put in these central lines for faster administration, but if you slow down and think about it, it actually makes more sense to administer blood peripherally.
And what we're referencing is Poiseuille's law. And if you look into it and do the deep dive, one single 18 gauge peripheral catheter runs at about gravity about 100 mils a minute. All three lumens of the triple lumen run at around 90 mils a minute. So that one singular 18 gauge peripheral runs faster than all three of the triple lumens combined.
All right, so disability, neurostatus, and GCS, that's something that we often kind of do right off the bat while we're assessing their airway, the breathing, and the circulation. Hi, sir. My name is David. I'm going to be your nurse. Can you tell me your name and where you are right now? Those are some things that we do pretty early on, but this is a good reminder to get a solid GCS. Every patient, and I'm sure that Christopher will let you know that on all the trauma sheets needs a GCS. Every hour. So don't forget the every hour thing, but at least in your initial assessment as well. And then the color, the motor, the sensation of all the different extremities. Not only are they present, but how good is the quality of the pulse on each extremity. And just like we would rate our neuro exams for our stroke patients, we also have to test their strength.
The last one's really important. We'll briefly touch on it now. We're going to go into more in depth in a little bit with it with the lethal diamond, but it's important to get your patient completely naked and you're looking at every part of their body. The temperature in the room should be set so high that you are sweating because you're not the one being cared for. You're not the one who's losing blood and losing heat. Every patient gets naked, rewarmed, whether that is with blankets, Belmont, warm fluids, warm product, or the bear hugger. This also goes a little hand in hand with the secondary assessment. You should be inspecting every part of their body and palpating every part of their body. It's hands on the patient. It's not necessarily just looking, because you really don't want to miss an injury or miss a GSW to the back that is bleeding out and you have no idea where it is. Every part of the body needs to be looked at, inspected, and palpated.
All right, the lethal diamond.
You go ahead.
All right, so we're fighting over this slide. Who's going to present it? So there's 4 things that we really have to be worried about anytime a patient's in our trauma bay. Their acidosis, due to potentially their decreased respiratory drive, the increased amount of lactic acid in the blood from their body being under so much stress. Coagulopathy. Anytime we lose blood and replace blood, it's still never quite as good as patients that are either receiving whole blood or the patient's own blood. And hypothermia, which is why exposures are a really big deal. Hypothermia leads to increased / decreased coagulopathy, and really has a pretty terrible cascade further down the line. For patients that are hypothermic, while yes, it does slow down some body processes, trauma is not the time where you really want to be doing that. And then the 4th part, which is, I think, kind of going to be hitting the EM streets pretty hard in the next year or two, is hypocalcemia. As we lose blood and as we become hypothermic, the amount of free calcium within our bloodstream decreases, and that has a direct effect on coagulopathy as well as the acidosis. So all of these 4 are very intertwined, and it's something that we need to constantly be thinking about.
Just a couple more things to this. As you lose blood, you lose oxygen carrying capacity. You switch from an aerobic metabolism to an anaerobic metabolism that creates your acidosis. As you're continuing to lose blood, you're losing heat. the clotting cascade works off of body heat and temperature, and the pH. So as your acidosis gets worse, your clotting cascade gets worse. That kind of touches on the hypothermia. And remember that when we're giving blood products to patients who are likely already hypocalcemic prior to even arriving to the hospital, the part of the components of blood products to prevent them from going bad binds to the calcium in our body and decreases your calcium. So multiple factors are decreasing the patient's calcium in the body, which leads to myocardial instability and inability to contract the heart. So the protocol, the MTP protocol UVM, has a amp of calcium carbonate getting added in at the end of the second unit or the second round, and every other round thereon. It's important to look at the calcium on initial draw and have an idea of it, and even being more judicious with giving or more aggressive with giving calcium early on to give them a better outcome.
Is there talk about getting the ionized calcium added to our trauma labs, or do we just need the regular calcium?
So the ionized calcium is better, but the calcium in the CMP is enough. You can also get the iCal off of the ABG that's drawn and just do full lights with it. That's going to be your quickest way to do it and get the fastest result. But yeah, as you get as those labs start filtering back in, if you're on the computer, just give it like shout out to the room. You know, this calcium is this. We're low. What do we want to do for that? Do we want to give gluconate? Do we want to give calcium carbonate? That stuff. So. All right, we've got 3 minutes. Yeah, the last thing is damage control resuscitation surgery. This is based off of, a lot of this is based off of military. The capacity of a ship to absorb damage and maintain mission integrity. So the important part of go back to this positive fast exam patient with a liver rupture bleeding out. It's important what we do in the ER because we have downstream effects. The damage control resuscitation surgery is the ER doesn't fix it. The OR necessarily doesn't fix it initially. It is going to the OR, controlling the bleeding initially, packing, sending them up to the ICU for 6 to 48 whatever hours, and fixing that lethal diamond, replacing their calcium, fixing their acidosis with good vent settings, making them warm, and fixing their coagulopathy with TEG-guided resuscitation, giving them the best opportunity to go back into the OR and have a prolonged surgery to definitively fix what's going on. This is early blood product with permissive hypotension because if we have a pelvic binder on and they're intrinsically making some clots in those distal arteries, we don't want to send their blood pressure through the roof and pop off those clots and make their bleeding already happening or already worse. It's avoiding iatrogenic saltwater drowning, avoiding crystalloids, because it's going to make every part of the lethal diamond worse. Quick arrest and temporization of the uncontrolled hemorrhage, whether it's extremity or internally. And then really quickly going in, packing into the OR, packing the bleeding, fixing the gross hemorrhage, and then going up to the ICU, fixing their lethal diamond and bringing them back for further definitive repair. So that kind of concludes our brief, 30-minute touch on this. We have a couple other options, or other education opportunities that are coming out in the next week or so. You may see some of the members of the education committee coming around with, we've written this up in kind of a one-page format. You may see some of them coming around and talking with you, seeing if you have any questions, and kind of going over this process on a more kind of in-person basis. We're also looking to do some trauma simulations for one of our upcoming PDA days, getting that into potentially a video format and walking through in a low fidelity environment, just in an effort to get more people comfortable. Also, look for trauma sims monthly if you're interested in doing that, working closely with the ACS team.
Awesome. Thanks for listening.
Thank you, guys.